Hey, good afternoon, good evening to everyone. Sorry, we're a few minutes late. I just had a busy day in the clinic, but now ready to do this. So thanks so much to everyone who has taken time out of their evening to spend with us here. So I want to make this as interactive as possible. So I'll go through some slides and some thoughts on erectile dysfunction, and then please in the chat box any questions you may have, please send them in anonymously. We'll at the end go through them and answer anything you may have. So yeah, okay, let's do this. So my name's Paurush Babbar. I am a urologist with the urology group, and I did my medical school education at Wake Forest University. I actually did my undergrad there as well. I originally grew up in Melbourne, Australia, and then moved to the States for high school. So I've been here a little while now, but spent my formative years down under. So then I was fortunate enough to do my residency at the Cleveland Clinic, which I think is the preeminent urologic institution in the world, likely. And so they got a tremendous breadth of experience in things like kidney transplantation, kidney stone surgery, oncology, and always what drew my interest and passion was men's health, penile implants, prosthetic surgery, and then genitourinary reconstruction. Just was the ability to impact someone's life is so immense with these procedures. So I really honed in my craft on this and was lucky to be kept on for an extra year of specialized fellowship training in these matters. So I see patients out of Eastgate and Norwood, and those are some of my specialties that I specialize in. So erectile dysfunction, the topic of tonight's conversation. So what is it? Who has it? What causes it? So the definition of erectile dysfunction is that it's an ongoing inability to achieve or maintain an erection firm enough to have sexual intercourse. So this definition suggests, and I certainly think this is a subjective definition, right? So for one man may be a good erection, for someone else may not be acceptable. So it's certainly something that when I see patients, we want to evaluate. Do you have issue initiating erection? Is it maintaining an erection? How long has it been going on for? We take a full history, what medications you're on, stresses in your life, diet, are you diabetic, surgeries, so things like that. But it's very common. And so 1 in 5 American men over the age of 20 will experience ED in their lifetime. And definitely more than half of patients over the age of 50 will have some degree of erectile dysfunction. So it's approximately 30 million American men are affected, so it's an extremely common problem, and we certainly are not seeing close to that many men come in. So most men are actually burying their head in the sand and just living with it, which is certainly not needed. So even getting on today's webinar, I commend everyone who's here just to this is a great first step in taking ownership of your health and being partners and trying to make a better intimate life for you and your partner. So how an erection works, I mean, this is maybe a little more in depth than we need to go, but essentially it's a matter of blood flow in and out, right? So there needs to be more blood flow in than there is blood flow out, and that's what gives you an erection. And then certainly there's some contribution of the nerves as well. So if there's a breakdown in the arteries, veins, nerves, I mean, this can be a big part of why men experience erectile dysfunction. So common causes of erectile dysfunction, we think that medication, so some antidepressants, antipsychiatric medications, some prostate cancer drugs that cut your testosterone levels off, these can affect erectile dysfunction. Pelvic surgery, so if you've had a colon resection for colorectal issues, Crohn's disease, prostate cancer treatment is a big one that we see that can cause erectile dysfunction. Then low testosterone is important. So in many men, I will check a testosterone level. We'll ascertain, what's your sex drive. And something, it's not that low testosterone repleting it's going to get your erections back to when you were 20 years old. I think that, but if you don't replete the testosterone, sometimes it's not a fertile ground for the other medications for erectile dysfunction to help. radiation therapy, whether it's for prostate cancer, colorectal cancers, things of this nature, that can absolutely affect some of the nerves that go to the penis and can cause erectile dysfunction. Then depression, anxiety. This is a huge cause, and so certainly since COVID, I've seen more patients, younger patients with erectile dysfunction. I think stress and depression, anxiety has played an absolutely critical part in patients' erection issues, and then other things like diabetes is a huge cause of erectile dysfunction. It affects not only the arteries and veins, but also the nerves that predicate erections, and then cholesterol. Patients who have cholesterol, can think about that. Those plaques that we worry about that cause cholesterol, if they are in the penile vessels, then you have impaired blood flow to the penis, and then that's what erectile dysfunction is. So really, it's just there's many causes, and that's something that we parse through in our history and physical. So to reduce your risk, I mean, this we've been hearing since elementary school, but it's so important. Like making sure your diet is as good as can be. Exercise is important. Losing weight is absolutely critical. Limiting alcohol, smoking. I mean, that is the number one thing that you can do to improve your health. If you're smoking, your erections are not going to be good, plain and simple. So you need to quit that, and that is critical. Reducing stress, sleeping well. So a few things that urologically I want to touch upon tonight that are related to erectile dysfunction. So low testosterone. So 40% of men over the age of 45 may have a low testosterone. So like I said, it's something we like to check during our evaluation. Peyronie's disease. So this is a adult onset acquired penile curvature that can be seen, and we sometimes think that when patients have erections that are not as rigid as they should be, and there's micro trauma to the inside lining of the penis, they can get some scar tissue build up, and that curves the penis or hooks the penis. And so that curvature in of itself is not the biggest deal if it's a small curve, but some patients is debilitating where they have curves that are really acute and they can't penetrate anymore. There's pain to their partner. So that's important to look into too. And then certainly prostate cancer treatment, whether that's radiation, surgery, hormones, all these things can have effects on erectile function. So low testosterone, a man's body normally produces testosterone from the testicles predominantly, and then as we get older, the testosterone levels can start going down, and this can have a big effect on things such as fatigue, loss of energy, decreased muscle mass, increased fat, reduced sex drive is a huge one that we will ask about, and then erectile dysfunction. So repleting your testosterone, if it's low, it can be absolutely critical. So there's many options for it, and that's something that we would talk about and decide what's best for you. So there's topicals, gel solutions, there's oral medications that we kind of we use here and there, but the insurance coverage on that and the nasal spray is pretty shoddy, and then patches, pellets, injections. So and we through our pharmacy replete that, and we have a team of PAs that are doing an excellent job to help with monitoring, because it's important. Sometimes patients go to these low T clinics. I would, you can go to them. I would just ask them, where did they do their urology residency? Where did they do their fellowship? I think the answer is going to be that they're likely not trained in these matters. And so, pumping the testosterone super high into the thousands to bodybuilder levels, you'll feel great, but then that's where testosterone gets the bad rap when you have a heart attack or a stroke and you die. So it's that you want to maintain it in a tight range, and too much of a good thing is a bad thing, and then also having a low testosterone is a bad thing. If you get super put on a lot of weight and then become diabetic, and that's a problem too. So it's important to maintain that range. So we really are, pride ourselves on managing it per guidelines in the right way. So Peyronie's disease, so this is what I alluded to, adult onset acquired penile curvature. So we think that when patients are having sex and there's a little bit of buckling to the erection, there can be some micro trauma in the inside lining of the penis. 9 to 12% of men are predisposed to this over the age of 50. They get scar tissue that you can palpably feel on exam. And then if that happens, then the penis can hook, because the scar tissue is not as elastic as regular tissue. So in of itself, no penis is arrow straight. There's a little bit of a tailed curve. That's fine. As long as you can have sex and, there's no pain to the partner, let it ride. But, when it starts becoming, 30, 40 degrees, it can be pretty debilitating. And so we do have some treatments for this. there's a traction device called a Restrex out of the Mayo Clinic in Rochester, Minnesota, which helps to bend the penis in the opposite direction of the curve, and when used for a few months can decrease the curve. Then there's Xiaflex. So this is a injection directly into the scar tissue or that fibrous plaque that's in that diagram there. It's an 8 injection course over a few months, and on average it can decrease curve about 17 to 25 degrees. So it is a good option in certain patients. And then lastly, there's surgery. If patients want a one and done solution, then we can do a plication or excision and grafting procedure. Rarely, if the curve's enough, then to straighten it out. And then if you have concurrent erectile dysfunction and penile curvature, the gold standard is to just put a penile implant in that will straighten the curvature and then cure the erectile dysfunction so that you're able to have sex again. So this is something that we absolutely want to look at when we see you in the office. Then prostate cancer treatment is another very common cause of erectile dysfunction. So whether that be radiation, brachytherapy, seeds, surgery, hormones, and then some of the less common options, but cryo, proton beam, HIFU, these can cause erectile dysfunction because the nerves that predicate erections run on the side of the prostate. So if there's just any scatter from the radiation, or when you take out the prostate, even if it's nerve sparing, the nerves can be a little stunned, and so there is some evidence that this is what causes erectile dysfunction in prostate cancer patients. So really most types, or I'd say all types of erectile dysfunction can be treated. The first step is coming and seeing us and taking ownership of your health. And so some of the treatments that we would want to talk about are oral medications, vacuum devices, ultrasound wave therapy, injections, and penile implants. So kind of going through these one by one. So oral medications, namely the ones that we've heard most of, Viagra, Cialis. So these PDE5 inhibitors, they increase blood flow to the penis. So they do require sexual stimulation with them, and they're effective in about 50 to 85% of men. I would say that in the early stages of ED, when patients have mild to moderate ED, these work very well, and patients do well with them. But just like any blood pressure medicine, diabetes medicine, at a certain point you may have to increase the dose, then you hit kind of a max, and then it may not work. But in the beginning stages, I think these are good. Now, some patients do have some of these debilitating side effects that are listed below. I take it back. For some patients, it's debilitating. Most people, it's fine. But so once in a while, patients they don't want to continue the medications. Now, so the two main ones, the most common ones, Viagra and Cialis, or sildenafil and tadalafil. So the Viagra, sildenafil takes about 30 to 60 minutes to work, lasts for about 4 hours, and should be taken on an empty stomach generally. And then the other one is Cialis. So this one, they call it the weekend pill because they say it can last up to 36 hours. So take at least an hour before, maybe 2 to 4 hours before intercourse, and can be taken with or without food. And there's actually a daily option I kind of like to use a lot of times. So you just take a 5 milligram daily dose that actually helps with voiding or peeing as well, because it can open up the prostate in older gentlemen, just so that you can pee a little better, and it helps with erections. And then you can take it daily, and then before sex, if it's Friday night, you're gonna have sex, so then a few hours before, you take 1 to 4 extra pills of that 5 milligram dose as a boost, and that can sometimes help. So, and generally these medications are not covered by insurance. So we have a really good service provided by our in-house pharmacy. Melissa Reuter, who runs that, is excellent, and there's no waits. Like you get at your local pharmacy, we mail it discreetly to your home, no membership cost, but and very reasonable prices that we would get these medications over to you. Vacuum erection device. So this is, the picture will show a little better. So this is a hollow tube that goes over the penis. They're both hand and battery powered pumps. Also, one, it essentially just pulls blood into the penis, and there's generally an elastic ring you'll put at the base of the penis to trap the blood there. So I think it works well, but the issue is that many times when you take that plastic tube off, the erection goes away in spite of sometimes having the ring. So the discontinuity rate of vacuum erection devices is high, but I do have some patients who do use it and like it. Now, I think there's a good role for vacuum erection devices in what's called pre-penile implant prehab, where before a penile implant is put in, we'll go more into that. Using a vacuum erection device before could potentially help get a little bit more length to the penile implant. I'm not talking like inches, maybe a centimeter or so, but every little bit helps. So vacuum erection devices, though, are another option. So next is this ultrasound wave therapy, or Alma Duo. So this is kind of the hot topic in men's health and erectile dysfunction treatment right now. So this is an ultrasound wave therapy that we offer at 6 quick 15-minute sessions that are painless and no expected side effects for all the randomized clinical trials, no downtime, no pain, and can help restore natural function. So the key in all this is we want to ascertain that you have mild to moderate erectile dysfunction. So if you're already on injections or you're a severe diabetic, I'm not sure if this would help that much. It's not going to hurt anything. So all the randomized trials out of Israel and Europe show a 2 to 4 point increase in IIEF scores with focal shockwave therapy, which is what Alma Duo is. So now you have to be careful. A lot of these men's health clinics are peddling radial shockwave therapy, which is not shockwave, which none of the trials support, none of the randomized trials support. So essentially the focal shockwave has to be run by a urologist's office. The other type of shockwave can be run by anybody. Okay, so it's like a same FDA class as a photocopy machine that anyone can buy, but the one that we have to run is a medical device. So, but I think it's a good option in patients who have some benefit to Viagra and Cialis. It can help to boost those erections along a little bit in patients with mild to moderate ED. So we want to select the right patients for this, and so this is how it works. It's a focused, low intensity extracorporeal shockwave therapy. We treat multiple areas of the penis per the randomized trials, with the handpiece. And, like I said, it's randomized trials have shown that it can help. So, all right. Why, to consider if you're going to do ultrasound wave therapy with us. So the main thing is we're urologists. We do this every day, spent way too many years of my life training for this. But anyway, so we're the first group of urologists in Cincinnati who offer this. We have a staff of ED experts, and we really look at the medical history. If we think you're not a candidate, I'm not going to say, oh, you should do it. Absolutely not. I want you to get the right therapy for you. That's all. And so if that's ultrasound wave therapy, then that is. But if it's not, if you have severe ED and you need a penile implant, I do the most of those in Ohio and Michigan. I mean, we will get that in, so whatever needs to be done, that's the key. It's going to be individualized for you. So this is just the QR code, just to, learn more about it. So ED treatments, the one injections is another one. So this is essentially you self-inject a medication directly into the penis, and then the erection typically begins 5 to 20 minutes after the injection. Works well. I think the injections are good, but the spontaneity certainly is lacking because, you're getting in the mood, then you got to go down to the freezer because they have to be refrigerated or frozen generally. Got to thaw it, inject, then go back, and it takes a little while to kick in. So that can be a bit of a problem. And then there can be some bruising and swelling that can be expected. And then there is a low rate, but definitely a rate of an erection lasting too long. So there's definitely some side effects, but it can work well in well-selected patients. So now there is, once again, a discontinuity rate on this is decently high because of the spontaneity, bruising, and if patients have that prolonged erection, they don't want to do it anymore. But I think it is a good option before someone heads towards surgery for their erectile dysfunction. And then last but not least, the penile implants, right? So this essentially is a schematic. So there's 2 cylinders that sit in the erection chambers of the penis. There's a pump that sits in the scrotum, and a reservoir that sits in the abdomen. So when you want to have sex, you pump up the pump that's in the scrotum. It pulls the fluid from that reservoir into the 2 erection chambers in the penis, and it makes it rigid. And then when you're done, you place that little deflation valve, which is on the top of the implant right here, and it goes down. So you can have sex as long as you want. So even after a patient ejaculates, you can keep going, which is a good perk, I guess, of the penile implant. But the satisfaction rates are above 90% for patient and partner with the implant. And so, yeah, I think so. Essentially, it's a good option. I think the complications we think about with a penile implant are the risk of infection, which is about 1 to 2.5%, and then the risk of the device failing because there's fluid that moves back and forth. So just like your car tire can pop a leak, this could leak. The risk of that's about 6% at 7 years. So 94% of these are still working 7 years after they're put in. I think it's a good option. I think sometimes patients dismiss this, like, oh, I'm not having an implant put in. It's like, all right, I mean, that's fine. I mean, if you don't want to have penetrative sex again, that's totally your prerogative. I mean, this is a totally quality of life thing. But I think we have to broaden the way we think a little bit, right? Because, I mean, not to be crude about it, women get breast implants and we don't bat an eye about that. And that's a cosmetic thing generally. I'm not talking for breast cancer patients, but whereas this is a functional implant. I mean, this, it works in a way, and when you want to have sex, it's up, and when you want to have it go down, it's flaccid. So I think we need to not have so much stigma about the implant and just be open-minded. And I think it is an excellent option. It's an outpatient procedure. It takes about an hour and 15 minutes to do. You go home the same day with a catheter and a drain. We take it out a day or two later, and then we activate it about 4 weeks down the road. So yeah, it's something to certainly consider. So yeah, we have a little video of the implant that we will show. So this is there's two companies that make the implant. This is this is the Coloplast implant. I mean, they essentially work the same way. So there's that reservoir that's in the abdomen, the two cylinders that sit in the penis, and the pump that's in the scrotum. So it's fully concealed, right? So if you're in a locker room, no one's going to know you have it. MRI safe. If you're in an airport metal detector, it won't go off. So you give it a few squeezes, it's pulling the fluid from that reservoir into the cylinders and ready to go. And then when you're done, you find the deflation valve, you press it, and then the other hand just chokes the penis. You don't have to, but that helps to just push the fluid a little faster back into the reservoir, and it's down. So yeah, no, I think it's a very good option in certain patients, and so it's something that we consider and talk about as well. So yeah, so that's what I have tonight. If you have questions, please send them along. Would love to, have a discussion about it. So I have a few questions here, so I'm just gonna start going through them. Okay. So one question is, what is the cause of a burning feeling with ejaculation? So could be many causes. The one that comes to mind when I hear them, I mean, we have to take a look, but prostatitis is one. So that's an infection or inflammation of the prostate, and that can sometimes be the cause of burning during ejaculation. So that comes to mind most for that. Next question is, what does an implant cost and how long of a procedure? So generally, this is covered by commercial insurance, Medicare. We'd have to run the numbers, but it is now an out-of-pocket cost of an implant is about $20,000. I mean, give or take a little bit. So without insurance, it can be pretty pricey, mostly for the cost of the implant, actually. And then how long does the procedure take? Probably an hour to hour and 15 minutes of actual operative time. You got to add on a little bit of time to go to sleep, a bit of time to wake up, and then we watch you in the recovery room for about two hours or so. Make sure you're waking up fine and able to drink some fluids and things like that. But it's an outpatient procedure, which is great. What is the recovery time like? Great question. So essentially what I tell patients is the first week you should take off work. You will have some bruising and swelling, but if you ice it and things of that nature, it's generally not maybe as bad as you would expect. Now, the main restriction is for the first 4 weeks, no lifting over 15 pounds. And then, no pools or hot tubs for probably the first 6 weeks. You got to let the incision totally heal. But I'd say by 2 weeks out, people are like 85% recovered. There's maybe some minor twinge at the instant, but you're pretty good now. If you do a lot of heavy lifting at work, you may have to be put on light duty for that first month. But otherwise, a lot of guys who do desk jobs, they're back the second week at work and doing well. So yeah, that's it's a pretty seamless recovery in most cases. Is Almadua cost covered by insurance? So that's a great question. In Israel and Europe, it's in the first line of the EAU guidelines, and it's covered. In the United States, we're always a little behind on innovative medical therapy sometimes, so it is not covered currently by insurance. The cost is $2,000 for 6 sessions. So yeah, it's an out-of-pocket cost. So that's why we want to screen you and make sure we have the appropriate candidate. What medications can cause ED? Good question. A lot of psychiatric medications, antidepressants have been linked to it, prostate cancer medications that cut your testosterone level down. So if you have cancer, we need to do that. So those are some of the ones that come to mind. Some blood pressure medications, lisinopril potentially is linked to it. So there are definitely medications. Now, I would never have you stop, if you're on an antidepressant, I'm not going to be the one to say stop it. But, in concert with your psychiatrist, for instance, we would discuss it. But, it's a plus minus. Now, is it like stopping one medication will get your erections back to when you were 20 years old? Probably no. It's probably a multifactorial thing that builds up over time, right? But, but we do definitely want to look at what medications you're on. Blood pressure medications affect erections, correct? Yes, I think some of them can. How much, or does it depend upon the medication? I think it depends upon the medication. And, I think there's some effect, but like I said, I think it's multifactorial. I don't think you can just pin it on one thing. I think the body is a much more complex thing. And so, as we age, the blood flow may be impaired. Cholesterol, like if you have high cholesterol, that same plaques that build up in your coronary vessels that we worry about for heart attacks, the same thing happens to the penis. I mean, you can't, it's a dynamic, system of blood vessels. So the same pathophysiology applies. So yeah, I'm 75. And for the last 10 years, I have experienced delayed ejaculation. What would be some of the causes? I have mild Peyronie's and ED. I have good blood flow around the penis. So delayed ejaculation, I think, is one of the hardest things to treat. Okay, I tell patients that when they come in, I don't think we've tried a few things, cabergoline. People have tried Adderall, which is, a class 2 psychiatric drug. And we don't have a good solution, in my opinion, right now. What are some of the causes? I just think that as we get older, okay, the body starts shutting down the amount of ejaculate you're making. And, the body knows, okay, most 75-year-old guys are not trying to have kids. So that function, in essence, kind of shuts down. I would check your testosterone level, make sure that's fine. The ED could certainly contribute to delayed ejaculation, but, we could try some treatments. But I tell patients, it ends up being sometimes maybe a little frustrating for patients. Sometimes, having erectile dysfunction is a cause of delayed ejaculation because you can't keep your penis rigid enough throughout the session of intercourse, and it gets hard, and it goes down, hard down, and you're not able to go all the way. So sometimes the penile implant can help, especially if you have mild Peyronie's disease as well. So the implant would straighten the penis, make sure you can have sex as long as needed to hopefully ejaculate. But I think that there's a difference between orgasm and ejaculation. So as you get older, you may not have the ejaculate volume that you used to, but hopefully you can still orgasm. But once again, delayed orgasm can be difficult to treat as well. So but there's options, but they're probably, I would say, there's nothing that's like foolproof. I think we got to try a few things and see what works for each patient. Can thyroid medication affect ED? I think it's possible. It's not something that I think about every day, but certainly hypo or hyperthyroidism can cause erectile dysfunction. So I think if the medication is not, maybe not titrated appropriately, it's potential. But not one that I would say comes to mind right away, like some of the other ones I mentioned. Is lisinopril, if lisinopril causes ED and you change them, is there a chance ED goes away? I guess anything's possible, but I mean, I think if you're on lisinopril, you have high blood pressure. I mean, suggests that there may be other things going on. You can try in concert with your primary care, is what I would say. I think you absolutely have to consult with them. Do not stop it on your own and see. But I'm not convinced that it would be 100% the cause. I think I would look into your testosterone. I would see, do you have a response to Viagra, Cialis, things like that, and go from there. What can cause decreased sensation? I think diabetes is a big cause of decreased sensation. There's peripheral neuropathy, or the nerves that have dampened signals in diabetic patients. Decreased sensation, I feel like getting asked like the things that are difficult to treat. I mean, I think that's more of a nerve issue generally. So that can be difficult once again to treat. And it's one thing that it's fully subjective. I can't, we don't do EMGs or anything for that I know of. And so it's a difficult thing to treat, but I'd say blood sugar is a big one that needs to be looked at. But yeah. That's all the questions I have. If there's any more, please send them over. Happy to keep going with any more, but no, thanks to everyone for tuning in. And so, yeah, let me just give our contact information here again. So if, please, the main thing is come in and see us. We also have a new doctor who started in Northern Kentucky, Dr. Wang. He's excellent. He also did a fellowship in men's health and andrology, and he sees patients there. So if you're there, you should definitely go see him. And Brooke Edwards also is in Northern Kentucky who does this, and Dr. Campbell in the north part of town. So, we have a lot of experts who we specialize in erectile dysfunction. And so I think, please reach out to us and, let's talk. That's what we want to start with, and see how we can go, and if we can help you. Absolutely. It would be our honor and pleasure. So I think that's all the questions I have, and yeah, we look forward to seeing you in the office. So thanks so much, and thanks for tuning in. Have a nice evening. So see ya.